All right, so I want to give just a really quick update on Leadership Councils for 2018 before we dive into our presentation. As hopefully all of you remember, we did a survey around the end of last year, sort of asking folks what they want Leadership Council meetings to look like coming into this year. Most of the people in this room will end up on either one of our collaborative planning teams for the demonstration work or one of our many other technical councils that we've started, like the Provider Champions Council and the Community Voices Council. So knowing that everyone's going to be asked to come to a lot more meetings, we sort of asked whether or not folks still wanted to do a monthly Leadership Council meeting in the same format. What we really took out of that survey was that people find that this monthly, that this monthly gathering is really valuable, but everyone else did agree that a lot more is going to be asked of everyone. So what we have zeroed in on is we're going to do a quarterly in-person Leadership Council meeting starting right now. And that'll be a good chance for everyone to get in the room together, bring together all of our regional partners to sort of share updates on what's happening around the region. And then we'll continue doing a monthly meeting, but outside of the quarterly, it'll just be a webinar. We'll have that time to sort of do a pop around of updates from the different collaboratives from each of our county and the different technical councils and the work they're doing. So we still have a monthly chance to touch bases for region and sort of zero in on all the different activities happening. Any questions or feedback on that? All right, great. So we'll be sending out sort of a calendar of when they're going to be in person, and they'll be looking forward to continuing our meeting here. All right, and with that, I forgot to introduce the folks on the phone. I apologize about that. So I'm going to do a quick round. I'll call you by first name, and then if you could just introduce yourself and where you come from. Dawn Sayers.
Hi, this is Dawn Sayers. I'm with Qualis Health and this region's Coach Connector.
Hey, Dawn. Deanna.
Deanna Davis with Applied Insight on contract with Empire Health Foundation for the ACH Technical Assistance SIM project.
Jenny Smith.
Hi, this is Jenny Smith, Newport Hospital and Health Services and the Pend Oreille Health Coalition.
And Kai.
Hey, good morning. I'm Kai Nevela. I work at Unified Community Health here in Spokane, and I'm also on the Better Health Together board. Morning.
Lynn.
Morning. I'm Lynn Kimball with Aging and Long-Term Care of Eastern Washington and Better Health Together board.
Marcus.
Hi, I'm Marcus Martinez. I'm with the Wellpit Indian Health Clinic, and I'm also a BHT board member.
Reese.
Hi, I'm Reese Holford. I'm with the Pediatric Transforming Clinical Practice Initiative.
Ron. Ron's on mute, but he's from the Campus Center in Kalispell Tribe. Sandra?
Hi, I'm Sandra Suarez. I represent Yakima Valley Farm Workers Clinic's Unified Community Health Centers.
Sharon?
Good morning, Sharon Fairchild. I'm with Providence Healthcare and also a member of the BHT board.
Tom?
Yes, my name is Tom Martin, and I'm with Lincoln County Public Health Coalition and with the Better Health Together board.
And Vicki?
This is Vicki Goosey with Adams County Integrated Healthcare Services.
Hey, Vicki. And is anyone else on the phone who I didn't call?
Yes, this is Dulcie Field from CBHA here in Ocala.
Good morning. This is Peter Adler from Molina Healthcare and also the BHT board.
Okay, good morning all. All right, so with that, I think I am ready to introduce our speaker. We are going to have just about 20 to 30 minutes of a presentation from Anne, and then I really want to leave as much time as possible for open discussion and questions from you all. I know as we're moving into action year, there's definitely a lot of swirl about what's coming and what's going to be asked of you all, so we're excited to have an open conversation today. So a little bit of background on Anne. She has recently retired after 15 years of serving as the first president of the Foundation for Western and Central New York. And that's an independent private foundation committed to sparking lasting improvement for vulnerable older adults and children, ages birth to 5. Anne has more than 40 years of experience leading public and private sector programs in mental health, community health, managed care, and philanthropy. And she was previously the Director of Quality Initiative at the California Healthcare Foundation and the Senior Vice President of Blue Cross of California. We are excited to have here today as Anne has been serving on the oversight panel for the New York District program and is also the chair of New York's Regulatory Modernization Work Group to integrate physical health, mental health, and substance abuse services. So I think she's going to have a lot of wisdom on some of the projects that we're about to be embarking on today. And with that, Anne, I'm welcome to welcome you on up. Sure. Hello, everybody. And you'll be able to use the mouse to just click through your slides.
Okay, thanks. I don't know if people on the phone have access to the slides.
Ooh, and just make sure we turn that on.
Oh, okay.
They can see the slides.
Oh, they can? Oh, great. Well, I'm really happy to be here. And I feel very much at home in Spokane. I live in Buffalo, which in New York is at the far end of the state, surrounded by 8 rural counties, and our foundation worked in those 8 counties. And it's very similar to what you have here in Spokane, where you have a large city surrounded by a lot of rural areas, including some tribes, a lot of retired people living out in these communities. Services are always an issue when you get outside the city, and it feels very comfortable to me to be here. That said, I don't know this area at all. So if I make a glaring error or I make a comparison that's really crazy, just forgive me for that. But in the sense of how we live in Buffalo and relate to state policymakers, how we relate to in New York, anything north of New York City is considered upstate, and they can go 10 miles out of New York City and satisfy the fact that they've dealt with the issues that we face in upstate New York. And I'm sure there are some similarities to that. I am, as it says on the slide, a co-chair of the Project Approval and Oversight Panel for District. That means we are the group that oversees the implementation of a $6 billion district program in the state of New York. We are not of district. I don't work for the state or in one of our, what in New York are called PPSs, but here I think are called ACHs, but they're the same thing. They're how the dollars are going to be spent in the community to address the priority issues. So I'm not from there and I'm not from the state, but I have a real good view of all 25 of those in New York and where they're being successful and where they're not. And when I was asked to come, it was with the idea of, what have we learned? What do I observe? Now, if you brought in the head of Medicaid from New York, you might hear a little different story than what I'm saying, because there is a real push to make this successful. And so you'll get a lot of good news. I like good news and want to share good news with you, but I'm also a realist and realize that some of this stuff is harder to do than others. And we need to be aware of that going in. So I thought I would start, let's just see how this works. I knew it. There. So I want to just tell you a bit about New York Medicaid and New York District so that you get the context of what we're going to talk about. Then I was going to talk about learnings from New York and then talk about lessons for you, but I combined them really because they're two sides of the same coin. And then I do, just like Hadley, want to leave a lot of time for discussion. So let me talk a bit about New York's Medicaid. There are over 6.5 million people on Medicaid in New York, 1/3 of the population. And we have the second largest budget for Medicaid in the country. So we're on the big end. And you can imagine, you can just, you have how many people on Medicaid here in Washington State? Roughly, does anybody know? Well, I think it's less. I think it's
Our
less.
region alone is just under 200,000.
Okay. Thank you, 1.9 million. So you can see kind of the difference in scope. And in New York, Medicaid is the largest purchaser of health care. So it had a really prominent role in healthcare developing the way that it did. In 2010, we were growing faster than almost any other state in terms of cost, but we weren't getting quality outcomes. Our costs were double the national average. We were 50th out of 50 in avoidable hospital use. So our system in New York was hospital-centric. And anything that happened outside the hospital was really only a feeder to hospital services. And we were 21st in quality. We were spending all this money, but we weren't getting the results. And I always believed that maybe it is going to cost that much to serve the Medicaid population. But if you're going to spend it, you better get better results than what we're getting today. And in New York, we had a very divisive political culture around Medicaid and really didn't have a strategy. So in 2011, the governor created what was called the Medicaid Redesign Team. And I was appointed to that team, and as a matter of fact, was the only appointee from Western New York. You know, that gets 6 miles outside of town and you're in rural New York. So we were appointed to come up with recommendations for reducing the cost and improving the quality of Medicaid services. You can see where MRT came into being, and you can see what happened to the cost curve. Now it's starting to go up again, and that's of concern and part of what we're trying to address with the DSRIP program. But you can see that the costs dropped dramatically. We're not so sure that the quality improved complementarily, and that's the challenge that I think we face today. So overall, New York has gone through this transformation. We started with the MRT. We moved into an 1115 waiver, which you're all familiar with, for $6 billion. We created 25 PPSs across the state, and now we're working towards a value-based payment program. And if you're interested in New York's value-based roadmap, you can Google that on the New York State website, and you can see how we're moving to that. So the PPSs, or ACHs, whatever you want to call them, the idea was to bring accountable care to New York, using $6 billion of the dollars that came in through the $7 billion Medicaid waiver. One of the things that happened in New York, I mentioned last night that New York has a chronic condition, and it's called Let the Flowers Grow. And so we have 25 PPSs, many of which cover the same geography and the same people, which is just, you don't have that here. Thank goodness. You don't need 2 PPSs in a community fighting over the Medicaid folks. The goal was to get to 1 per region. And as you can see, outside of New York City and outside of Buffalo, which is way at the left end, they have 1 per region. In Western New York, we started out with 7 proposals for PPSs. And we were able, through the foundation's work, to get them down to 2. We could not get them to 1. And so the Catholic system has 1 PPS, and the public hospital system has another. And you can imagine why those 2 could not get together in the final stages. But it lost for Western New York $100 million, which seems to me would have been worth combining efforts. Although on the other hand, I've seen where they've gone to 1, like in Central New York, but it really was a shotgun marriage. And people really didn't want to cooperate, but they did it. And now that's all playing out in the day-to-day work of the PPS. So there's a downside with forcing collaboration where the heart is not in it. So you can see many of the PPSs in New York are led by hospitals. And that has created its own issues and sense of disconnect between the hospitals and the community. And so they struggle somewhat, and I'll talk a little more about that. So before I go on into kind of the lessons learned, are there any questions or comments about how it's working, how it's structured in New York? Yes?
Are you talking mental health or behavioral health and medical costs combined, or do you carve out for behavioral health?
It's all Medicaid paid costs. So it's health, physical health, behavioral health, substance abuse, long-term care, anything that flows through Medicaid, services for the intellectually and developmentally disabled, that's the universe that New York is looking at.
And do you have a breakdown of percentage of total cost into those various areas?
We do. I didn't bring it with me, but I can provide it to Hadley if you're interested. One of the challenges, and I'll talk a little bit more about this, is integration of physical health, behavioral health, and substance abuse. In New York, we have 3 different state agencies, one for physical health, one for behavioral health, and one for substance abuse. And they each set their own regulations, and they each set their own licensing criteria, which are very different one from another. And that's become a huge barrier because one of the required projects in New York is integration. What do you call it here, where it goes both ways? What did you call that?
Bidirectional.
Bidirectional, yes, integration. And that's the team that I'm on at the state, is looking at the regulatory barriers to that true work, and there are lots of them. It's unfortunate at this point that they are only being addressed now because we're in year 3 of the program. And if those things had been addressed earlier, it might have been easier to get some of the integration that we wanted to see. Yes?
How or is New York addressing oral health?
Okay. It's not on the district radar screen, and it's a big problem. And I'm really happy you're from Washington Dental Service because we did a lot of work with you from our foundation in upstate New York, and have a program called Chompers that's working through Medicaid, but it's not really part of district. Any other questions about the structure? Yes?
So you mentioned, if you could talk a little bit more about the design of the PPSs, you mentioned that many of them are hospital-led. Who else is involved, and what are the relationships between the different players?
The question was about who else is involved in the PPSs and the relationship between the players. And I'll talk a little more about that when I get to the issues. But, you know, progress moves at the speed of trust. And building trust is critical in this work. And in some of the PPSs, it has never been built. The hospital is in the lead, and it's decided that if they're going to work in the community, it's because the hospital will work in the community now, and not contract with local groups, about whom they know very little, even if they exist. That hasn't been and those PPSs are struggling. If you think about 25, and we're in year 3, we have some real stars, and we have some real turkeys. And in between is pretty much everybody else, the natural curve, right? And when I look at why some seem to be struggling so much, is because they never really developed a community approach to this work and felt that if it wasn't exactly physical health, that it really wasn't something that needed to be paid attention to or was an extra. The ones that are really successful have embraced their partners in the community and moved forward together. So there were 12 possible projects that you could do as a PPS, and you could pick as many of them as you wanted. And the amount of money you were eligible for was a factor of 2 things: how many Medicaid lives you had, and the degree of difficulty of the projects that you took on. Well, when anybody's applying for a new activity, a new grant or whatever, you know, they're very optimistic. So they all picked more projects than they probably should have, and they set higher goals for themselves, considering that they really didn't know what they were doing. And they are stuck with those goals and with those projects. New York does not allow a redesign once you start. So I don't know if that's the case here, but if it is, you want to be really sure about the projects that you take on and the goals that you set, that they are achievable, that they are doable. But you don't want to lowball it either, because you won't get the money. So New York really had a number of ambitious proposers who took on goals that they really didn't know how they were going to meet them, and they're struggling now. I saw one other question. Is that yours? Oh, there.
You were talking about if primary and behavioral health had been focused on earlier, that you would have seen better results in terms of integration. So I just wanted to know if you could provide examples or talk a little bit more about what in particular.
Sure. Co-location, which is one way of moving to integrated care, is very difficult in New York because of different licensure requirements for organizations that provide behavioral health services and organizations that provide physical health services. If I'm a behavioral health organization and I want to bring primary care in, I have to have a linen room, a clean room, all these things that are required for physical health. On the reverse, in New York, if you're a physical health program, an FQHC or whatever, you only need one bathroom in your waiting room. If it's a behavioral health organization, you have to have two bathrooms in your waiting area for privacy and protection and all of that. Well, that makes co-location really difficult because neither one wants to go through the extensive licensure requirements to create a physical space where you can work together. The other thing is about certification of staff is very different on the physical health side than on the behavioral health side. So those are some things with the integration work group that we're trying to deal with through state regulation. CMS also has some barriers to that in terms of co-location for FQHCs and hospitals. There's some real barriers to that. And we wrote a letter to CMS, we, the oversight panel, wrote a letter to CMS asking about co-location, which they said was fine as long as it was, and they used the term, temporally distant, which meant that you couldn't have both services there at the same time. So you could have one in the morning and one at night, or one on Tuesday and Thursday, and one on Monday, Wednesday, and Friday, which just makes no sense when you think about the goal of integration. So as you develop your work, you are going to run into these kinds of barriers that nobody's really thought about in a variety of ways. You know, what is a community health worker? I don't know what you call them here, but they are very important in a community-based system. Do they have to be licensed? What does the state say about who can do that work? Are you able to just deploy them to do a variety of things? Are there certain scope of practice regulations that require a nurse to do X as opposed to an LPN or a CNA to do it? What are those regs and how do they interfere? And when I said if we had done that earlier, I think, you know, DSRIP is a very short time period. You're talking about changing the culture of health in our communities in 5 years. That's short in and of itself. But if some of these barriers are not addressed up front and you bump into them at year 2 or 3, it's going to take a long time. So you really need to think about this work as being in it for the long term. This is not a 5-year grant that when you're finished, you can go like this and say, well, we weren't totally successful. We were partly successful. Let's go back to doing things the way we did them. Because you can't do that anymore. There is no going back. There is only going forward. And how that looks will have a lot to do with how you function over the next 5 years. Any other structural questions before I move on? I have a really bad back. Would you mind if I sat down? This is killing me up here. Can you see me if I sit down? Okay. I'm sorry, but my back is distracting me from you. Okay. All right. So where are we now in New York? We're in the middle of the 3rd year. On pay for reporting, which is the easy stuff, and which you're going to be doing in the first couple of years, New York PPSs have earned about 95% of their money. Now we're shifting to performance metrics, and the earnings are expected to drop significantly. There's one PPS that predicts that they will only receive 25% of what they thought they would earn now that we're in the performance stage. Now, I have a lot of problems with that. First of all, I don't know how you motivate people when you put out that we only expect to hit a quarter of our goals. That's kind of demoralizing, isn't it? And how do you whip your staff up to achieve things if that's what you put out to the public? But that's what they have estimated they will earn based on what they committed to day one and what they think they can really accomplish. So that's a big drop, because in New York, we're talking about hundreds of millions of dollars. While yours is smaller proportionally, it's relatively as important in this with 200,000 Medicaid recipients as it is with 1 million. So if you're only going to get 25% of the money you put out there, I don't know how they're able to keep going. They said, well, they hope they'll exceed that. And I said, oh, great, so we can have a rally that says we're going to get 30% of our money. It's just a real demoralizing way to go. But we do expect the earnings to drop for a lot of reasons, which I will go into. Almost half of all of the Medicaid recipients in New York are engaged in one or another project. That doesn't mean that the outcomes are better. It means that one or more of the projects are touching over half of the Medicaid population. One of the things that we just learned, and I understand that same is true in Washington, is that dually eligible people are not going to count towards the goals that you may have set for yourself. In New York, the top 2 things that are looked at across the board are a 25% reduction in unnecessary hospitalizations and a 25% reduction in unnecessary emergency room visits. Those are the overarching goals for the state. Then each PPS has their own projects. The highest utilizers of emergency rooms in New York State are old people and people with intellectual and developmental disabilities who are both dual populations. So if they are pulled out of the mix, that's creating another tension in New York. Now, we didn't know that in the beginning. And the reason for it apparently is that it's very difficult to get Medicare data. So it's almost impossible to know what the utilization pattern is with Medicare recipients. We didn't know that in the beginning. So there are projects like Interact, palliative care, built into the PPSs. And they're not going to be able to earn money on those now because the majority is not, 80% of the population in both of those cases are duals. So there's an advantage to going later, which I think you are doing, because some of the lessons that have been learned, we've learned them and we've worked through them. And I think they are important for you to understand as well. So what I'd like to do is take the next 15 or 20 minutes and go through what I think the lessons are and the challenges to all of you that are going to be coming up. I'm a realist, and I want you to feel motivated and mobilized and hopeful about achieving the goals that you're setting for yourself. And I don't want to take that away from you. But I also want you to go into this with your eyes wide open. This is work. This is hard work. And one of the toughest things is revisiting some of the more accepted attitudes and beliefs about what works that we've never really tested. So some of you have been working in agencies for a while and you're doing work and you know that it's working, but the data may show that you're not getting the results you think you're going to get. So you're going to have to be able to let go of some of that stuff and try new things. And for organizations that have been struggling for a long time and have been working hard to achieve the goals that you've had on the table, to look clear-eyed at the data and say, wait a minute, maybe we need to try something different, because the data isn't supporting the anecdotal and the feel-good evidence that we have. That is very hard for people to do. And so I just want you to kind of be ready for that. I'm not saying you should toss out everything you've done till now, but when data enters the picture, it can tell a very different story than what anecdotes and counting things will tell. I'm running an agency and we see 1,000 people a year, and they all fill out a form that says this was very helpful to them. So we are doing what we need to do. Well, you're a behavioral health agency, and one of the things you want to do is have the people you serve stay out of the hospital. How many of those people have stayed out of the hospital? Oh, well, we don't know that. We know they like the service, they know they come back, but we don't really know what impact it's had. So prepare yourself for asking yourself some of those tough questions. What is the value proposition? What is the value add that we bring to the table that justifies us being part of this effort? That's the strongest message that I can give you. I hope it's not demoralizing, but you have to be open to thinking about new ways of doing things. Yes?
What are some of those baselines that you're seeing with behavioral health as far as value-based payments? How are you determining if they're getting better?
Well, I think that some of it will be proxies, but some of it will be, so some of it may be things like continuation of medication. How long is, they're put on meds, how are they prescriptions filled, et cetera. Admission into what we call in New York CPAP. I don't know what you call it, but it's the emergency unit for people with psychiatric outbreaks, if you would call that. How long people live in transitional housing? Are they able to get a job? When you're working with them, things that tell you that their life is different. Those are some of the things that I think we're seeing more of. I'll just give you an example out of New York. There are in Buffalo alone, there are 2 organizations that provide job training for people with psychiatric problems. Okay, one is paid by the state $30,000 a year to run this program with no subsidy for transportation. The other program, run by a different agency, is paid $100,000 a year with a $500,000 grant for transportation. And neither one can tell you how many of their graduates get and keep jobs. Okay, so now I'm negotiating. I'm a managed care plan or whatever, and I want to have a job training program. what do I do? Maybe 30 isn't enough, but maybe 100 is too much, and neither one can tell me whether their clients keep jobs. How do I negotiate with those groups? So that's an example, I think, of what we're seeing that requires a whole different thing. How long does, maybe we better stop just looking at them while they're in the training program. Maybe we have to see what happens to them down the line. And then use that data to evaluate our own training program. Does that give you an example?
It does. Is there funding for that? Have you seen that yet? Are there funding for people to actually follow people after treatment?
That would be part of the district dollars being used to add that component to the behavioral health organization. If district is not about people keeping jobs or therefore staying out of the psychiatric system, then you're probably not going to get funding for that. But if it's something that you can say is consistent with the goals of ACH, you should be able to get some funding for that. Anything else? Okay. Is this helpful? Okay. All right, so here are some learnings and what I call possible hurdles for you to. Big money and lots of players is a double-edged sword. When people in New York heard $6 billion, people just lined up for the money. They all wanted to be part of something, and we in New York, each PPS had to submit the names of their partners. And I understand you had to do that too. And everybody wants to be on the list, and everybody wants to be part of that. And before you know it, people's expectations are such that they will get money for a post training opportunity, or it'll be their first chance to get money for what they do today. And I'll tell you, people's eyes got really big in New York. And my guess is some of that is happening here, that they see this money and they think, thank God, we've been struggling for years on the tiniest of margins. And here's money that's going to validate the work that we do. I'll tell you that when it came right down to it, many of the folks who had signed a partnership agreement did not find a place in district, because no one really knew what the work was going to be. And once they figured out what the work was going to be, they had far too many partners on the list to spread the money. And so it is a double-edged sword. It certainly gets people interested, but it also begins to set a level of expectation that no matter how much money you have, it is not going to be able to be met. So how do you manage that? How do you manage people's expectations in a way that they're maybe not in today, but in 2 years as the programs develop, there's going to be a need for that. And part of that goes back again to what I believe is every organization's responsibility, which is to understand your value proposition. That job training program I talked about, how much should it be charging? What outcomes should it be able to commit to that the rest of the ACH can count on? These are questions that you'll have to be able to answer over time. And part of the role of ACH is to help you do that. I cannot overestimate the difference between a pay-for-performance culture. Hello? Did someone say something on the phone? Or was it my imagination? Is that little voice in my head? I can't tell you the difference. I can't overstate the difference between a pay-for-performance culture and a pay-for-work culture. Pay for performance says exactly that. If you don't hit the outcomes, it doesn't matter that you tried really hard or you worked really hard or you lost your staff or this happened or that happened. Pay for performance is a very, what I call kind of a cold-hearted, bottom line way to go. And ironically, in a true pay for performance world, if one of the organizations in your PPS does it all by themselves and doesn't share the money with anybody, and they reach the goals, they get paid. Historically, at least in New York, the state always played a role to make sure that the community was represented in various things, that social determinants played a big role in how grants were given, how things were managed. And in pay for performance, it's kind of like, you either pass or you don't. And that creates an environment that's very different from that kind of nurturing environment that we've seen from the states in the feds in their funding historically. And a lot of our PPSs were not ready for that. They really could not believe that they would be paid only if they achieved the results. And it was yes, but, we've done all this. We're in all these communities. We're touching half of the Medicaid population. Okay, but you didn't achieve the goals you set. But those goals were too lofty in the beginning. Well, you set them. So it's kind of as I said, kind of a cold-hearted, I don't mean to ascribe that personality to people, but it's a very black and white thing. You either hit your goals or you don't. So if you work together to set your goals for the work, you've got to be really sure that you're comfortable with the numbers, that everybody knows what the data is saying about how aggressive those goals are, because you're going to be stuck with them. And I say that not to strike fear in your heart, but to, again, just have you be realistic about what that might mean. Okay?
Can I ask a question?
Sure.
How did pay for performance affect the community culture around the collaboration of different groups?
It affected it greatly. It has taken what I would call, I don't know about Washington, but in New York there was kind of what I would call paternalistic culture toward community groups, and they were always included. They were always at the table. Even if they really weren't clear about their value proposition or what they were doing, they were always there and always got a share of the money. Now, they can get a share of the money through the PPS or the ACH, but a lot of it is determining, well, what value do you bring to the table? I know there's a CAO in here, and there's a housing and Meals on Wheels and some of those things. How you define your value is really important. We want to enter into a contract with the lead on this PPS or whatever, and we can deliver X for Y. And that becomes the negotiation as opposed to who should be at the table. You understand what I mean? It's just a different culture, and be very ready for that, because I think it was pretty shocking. Did that address your question?
Yeah.
What do you think of that?
Well, I think we're pretty collaborative as a community, and so it is going to change the way, it creates a competitive space, I think more so than we probably, I would anticipate it to create a more competitive space where we kind of jar against each other maybe potentially.
Well, I also, and again, I don't know this community, but what we found in New York is there were a lot more organizations doing the same thing than really was needed by the community.
Sure.
And so what it created was some real impetus to look at memoranda of understanding, even moving to some consolidation, because it was, again, as I told you, a chronic condition of let the flowers grow. So if you wanted another organization, well, you just create it, and you look for money, and if you get the money, you continue on. That's been changing in New York. It doesn't always have to be bad if it's done with respect and dignity, and there's a pathway out of where organizations are. that can be a positive thing. Yes.
So as a result of that, have agencies closed their doors? Have people been laid off? What's happened to the labor force?
It's interesting because we're only in year 3, and so pay-for-performance dollars are just beginning to flow. We have seen more consolidation. We haven't seen a lot of redeployment, which is one of the things I'm going to talk about, because I expected to see far more of that. And I think we're going to hit the wall on that soon, that redeployment of people is going to become more important. We haven't seen too many agencies close, because even if you're not on the district train, you existed before and you had some dollars coming in, and it's just this new amount of money that you're missing out on. But I would say in the long run, when I take a 10-year look over time, I don't think they're going to be able to survive if they're not part of the network that's moving care in the direction it needs to go. They'll become less, more ancillary and more unimportant, I guess. Not to the people they serve, but to the larger system. Okay. Yes?
I'm just wondering, I'm thinking of the term leveling the playing field. So when you talk about quote-unquote paternalistic organizations and an expectation that we're always kind of built into a piece of the pie because we're sort of foundational to service provision in the community, that's always made it difficult for, one, people with new ideas within those organizations. Sometimes the new ideas don't really get a voice.
Exactly.
Because they're more risky and they don't have identified funding
And
patterns.
it's rocking the boat.
Right, it's rocking the boat, which is what's happening now with the paradigm shift, correct? And then two, if I'm a smaller agency or a new player, it's harder for me to get into the funding pot. So has New York's experience been that if it's truly paid for performance, and I come in as a smaller agency, I come in and I can show metrics, or as a community player, I can go to a larger entity in the community and say, here's my out-of-the-box idea, here's what it's based on, I think it will work. Do you think that there's a richer ground now for those sorts of things to happen, or are we still going to be stuck in the same sort of, it takes so much momentum, action over inertia sort of thing?
I would say that it varies. The ones that are more successful are really cultivating the community for ideas and for creating opportunities for those ideas to be developed with some financial support. I can tell you right now, I work with an organization in Buffalo that serves people with intellectual and developmental disabilities, and they want to divert them from the emergency room. And so one of the PPS is investing in us helping to develop a telehealth capacity. And so they're providing seed money for that, not long ongoing funding, but seed money for new ideas.
So that would be the exciting thing, right? So if I have seed money, then basically it's my proof of concept.
And it might work, it might not.
Right.
Right, and I think those PPSs that are really entrepreneurial that way they're having great fun, and they're doing good things, and things are happening. The ones who believe that doing things the way we've done them is the right way, and we just need more money to do more of it, are struggling. So there is a positive side to that, and I want to make sure that's understood. I would bet that if I asked each of you to write 2 sentences about what a transformed health system looks like, we would have almost as many versions as we have people in the room. And that tells me that we don't have a common goal we're working towards. And I can't underestimate the importance of that. From wherever you come, if you're a hospital, if you're a community agency, if you're a behavioral health clinic, the North Star should look pretty much the same. And there's a place in that North Star for each of you. So if you haven't done that, I really urge you to do some work around where are we going? Where is this taking us? And part of that is where are you now? And that becomes a data issue. And that's tougher than we'd like to think that it is. But a common view of where you're going is very, very important. Here we go. Are the metrics useful? Like New York, your metrics, your measures are 2 to 3 years behind. So in year 3, you'll be able to get your baseline numbers of where you started in year 1. And you really won't know till year 5 what happened in year 3 when you put in a lot of these changes. So the data really works against us. It is not real-time data. I'm hopeful that some of the health plans may be able to help with data because they see it earlier than almost anyone. I know that they want to negotiate individually with organizations, and they should retain that right. But utilization data is pretty safe, I think, and something that you might want to work with them on because the state data is delayed and the Medicare data is unavailable. The other question, yes?
I'm sorry, just a question on data, qualitative versus quantitative. When you were talking earlier about the numbers don't always tell the story, is qualitative data being viewed as powerful, or is it still sort of the stepsister to numbers?
Well, I would say that if pay for performance if I were to estimate pay for performance on qualitative versus quantitative in our state, it's about 75 quantitative and 25 qualitative. And qualitative is looked to be kind of what I would call an early warning sign or an early sign about what the numbers should look like. Qualitative in a pay for performance world is suspect.
Yeah. Okay.
Like I said, you provide services, people love your services, they come back for your services. Okay, that's qualitative. You have the one example of the person who took your services and emerged and is now a candidate for the Supreme Court, right? So you have that,
yeah.
But that is not considered comparable to numbers.
So what your advice would be to really focus on the quantitative data. And if we feel like we have a qualitative story to tell, to figure out some way to quantitatively measure that?
Yes, yes. The story is important, but it also needs to be based in quantity. Now, I think one of the things I'm just going to ask you to think about here, and am I running out of time? Where's Hadley? Oh, am I running out of time?
Half an hour left.
Okay, so should I just continue?
Yep.
Okay. I know that you have a coalition in each county, and each of your rural counties is relatively small. And if each county does the same thing, you're going to have a lot of duplication of effort, and it's going to take a lot of duplication of cost to do a early intervention program in every one of the 8 counties. The way we did it in Western New York is the counties kind of formed their own sub-coalitions. So there were maybe 2 or 3. Because if you're too small, you don't even have an N that can give you the data. And Hadley said, out here, most of the state data, your data is suppressed. Well, that doesn't help you in measuring your performance if you're one of those, NA or the hashtags in the data sets. So you've got to figure out how you do your work at a scale sufficient to give you accurate data. Because you don't want to do all this work and have it come out that the N was too small in 4 of your 8 counties. Because you won't know how you did that. So I think that's a special thing that you have to be thinking about, is how do you do your work? I know within a county it's very collaborative, but how might some of that work be done cross-county? Not necessarily everybody, but cross-county so that you get the synergy, you get the scalability that this work needs. So I think that's a special issue here. Partnerships are tough. They really mean, as I said earlier, that progress moves at the speed of trust, that trust between and among the folks who are working on things is critical for a successful partnership. If you don't know people who are going to be working on this with you, you know, progress moves at the speed of trust, and understanding is the first step toward trust. I don't think I said this in here. I talked to Brian at breakfast about this, but I was asked to speak at every 18 months, New York has a learning symposium for everybody involved in district across the state. And there were about 600 people in the room. And so I was asked to speak, and I said, before I speak, I just have some questions. I said, if you work for a PPS, please stand up. And about 500 people stood up. So that means they're all working either directly or through contract with the PPS. I said, okay, if you have never worked in the community, in a job in the community, sit down. And about 400 of the people sat down. And the other 100 was still standing. And I said, if you did work in a community agency, a FQHC or a Meals on Wheels or whatever, but you never sat at a McDonald's across from a person or visited their home or did anything like that, please sit down. And there were 11 people left standing. Now, what's the likelihood of true partnership within a PPS when the understanding of the traditional clinical system about the value needed in the and able to be gotten in the community, how can you really have a true partnership like that? And that's why we end up in some PPSs with the hospitals hiring their own people to do the work that is already happening in communities by people who have been doing this work in communities for years and years and years. Some larger institutions don't even know about these organizations. So I think you're way ahead with the collaborative work that you've been doing. But true partnership is very, very difficult. And I urge you to really work at it and build trust. There's nothing like having a cup of coffee with somebody from an agency or an organization that you don't know much about. Because you'll find your way to a common solution. But don't take it for granted. And the bigger you are, the less likely you are to feel the need for other partners. So understand that about yourself and work with it. I mentioned this, understanding and trust. We've touched on this, about the capacity of community organizations. And one of the things that the foundation that I ran did, and it's an idea for Empire or other funders that you have, is we ran a program called Get Set, Success in Extraordinary Times. And what it was a program for this kind of, not one-person organizations, but this kind of next middling group in how to determine your value proposition. How to know what it is you offer, what it costs, how to put you in a position to be able to negotiate for your organization and for yourself. And that program, you would be in that program for 2 years, working with a consultant, some group trainings. There were always 8 or 10 organizations in a cohort. And we saw phenomenal results from that. And now 2 of the PPSs are adopting Get Set for their members because they realized, even though they're in year 3, these organizations are really not prepared to hold their own at some of these tables. And it's not because they don't offer good services or they're not responsible organizations. It's that they've never really thought about what is the specific value that we bring, what does it cost, how is our board supportive of that, all of the things that you require in a value-based purchasing world. So I put that out there because I think building the capacity of community organizations to hold their own is going to be really critical. You know, if I'm a big hospital, I can get training on something like that. If I'm a $2 million or $3 million organization, I'm not going to be able to get that for ourselves. So I don't want to put you on the spot there, Brian, but I do think it has worked out well to equip important community-based organizations to hold their own and do what they need to do. I talked a bit about regulatory barriers. Scope of practice is a big one. I don't know about Washington State, but New York has a very restrictive scope of practice law. Up until this legislative session, the only people who were allowed to put a person's pills into their pill box, you know, like if you were a home care worker, you couldn't do that. It had to be a family member or a registered nurse. They were the only two people allowed to do something as simple as putting the pills in the pill box. Not even a pharmacist could do that. They finally loosened that. But there are example after example of where the scope of practice has restricts people's ability to use all of your tools to achieve these goals. Licensing, as I mentioned, is another. I don't know how that works here. Because we have 3 state departments in New York, and each does its own thing. Just a quick example of that. I told you we're working on this regulatory modification thing, and we came up with something we call the limited integrated license, which would allow an organization like a behavioral health organization to offer some physical health services, and vice versa. It was kind of a toe in the water to see how this works. And it was all the way down the line, and it was ready to go into regulation. And the OASIS, which is the Addiction and Substance Abuse State Agency, says, that's too negative a term. We don't like the word limited. It feels too negative. And it was like, where did that come from? That came right out of... So now in the collaborative process, we have to figure out what to do with that. But one comment like that put everything on hold. So the state departments play a big role in this. I know they give money, they're pass-throughs for much of the money, but how they pass through, what their rules are, what they reinforce, and what they, I'll use the term prohibit, but I don't really mean that, what they don't allow, drives performance in many ways. So you need to make sure they're on board. If you really think about this, we want to build a community system of care, reducing unnecessary high-cost services, residential programs, move things to the community. At some point, you're going to have to look at redistribution of workforce. There can't continue to be as many people working in, well, let's use ER diversion. If you're able to divert half the people from the ER, you don't need all the people in the ER. Now, that creates an imbalance, and, you know, a good nurse working in an emergency room and a nurse working in a housing program make very different incomes too. So you have a redistribution from high-paid positions to community positions, which may be lesser paid. And how do you manage that redistribution or the, you know, the reassignment of work? As volume of work goes down on one side, it's like pushing the pillow, you know? You push it here, it comes out there. So you may not need all the people you have in tertiary and quaternary care or in hospitals where admissions are going to be diverted. Chronic care is one of your big initiatives. Chronic care diversions from hospitals is going to create a real issue within a hospital about both revenue and staffing. And how do you manage that? How do you manage that shift? Which, when you're successful, should really be happening in year 4 and year 5. So those are important things for you to look at as well. And then what's the role of managed care plans? I know there are a couple in the room, and eventually they will be taking over this contracting. And how do they prepare for that? How do they develop within the managed care plan the understanding of things like social determinants, of things like behavioral health, crisis stabilization, addiction recovery? You know, in physical health, a visit is a visit. In behavioral health, that same person may need to be seen 4 or 5 times during the week, or may need to see 2 or 3 people at the same time that they're there. And for a lot of places, in New York is one, you only can bill for one thing a day. Well, that isn't going to work like that when they start to negotiate for this much broader level of service. How do you value the supportive housing group that keeps people in a safe housing place as opposed to being on the street? How do you value that? So their role is changing too, and it's going to need to develop a whole new set of expertise that they can learn a lot from you about how that works. But they're going to have to develop and put it through their own sausage machine and look at risk and all of that, right? And but they're going to be the ones negotiating with you. So how they truly understand what you're doing is going to be really important. I mentioned earlier, and I'll just put a pitch in there, that I think short of negotiating, you're going to need data about utilization. And if they can help you with that, I think it would be a great public good. I understand, I've worked in a health plan myself, and I understand their desire to keep things close to the vest. But what we're talking about now is transformation of health, and it's a community good. And if they hold data that you can't get to test your the progress or the effectiveness of what you're doing, I think they could be a big help. So I urge you to continue a dialogue with the health plans about data on utilization that you might be able to get from them.
And I gotta give about a 5-minute warning.
Okay, I have one more. Year 6 and beyond. This is not a 5-year grant. You're in year 1, and you are at the perfect time to be talking about what comes after year 5. We know that the current administration in Washington is not going to continue these kinds of grants. So you have 5 years to build a relatively sustainable program that can continue afterwards. And if you have partners who really do see this as a 5-year grant, that when it was great, we'll chalk up our victories, and when it's over, it's over. And I've heard organizations in PPSs talk like that. Well, we'll do what we can, and then when the money is up, we'll go back to doing what we did before. And as I said, I don't think that's possible. So you can go into the future in a positive way, or you can go into the future in a deficit way, which will happen if you have not planned for post year 5. Okay? So lastly, I really think you need to challenge yourselves, individually and in your organization. Move beyond parallel play, which if you have kids, you know in the sandbox, they play nice, but they don't play together. And this is not going to work in parallel play. I like this phrase that silos are like weeds. They'll keep coming back unless you fight them and fight them and fight them. And so you have to be aware of that. Echo chambers are a big problem. If you only talk to people who think about this issue the way you think about it, you'll start to think you're right, when in fact you're just talking to other people who think the same way you do. So to the extent that you can set up cross discipline discussions, a hospital and a housing project, talking with each other, even at one of your meetings. If you can start to set these things up, it will break that echo chamber open. There's a book, I mentioned it this morning, called Trying Hard is Not Good Enough. And I think that's really a mantra for this. It is not going to be enough to try hard. I'll get Hadley the book and the name of the book, and you may want to look at it. And it asks 3 questions. The first question is, what did you do? The second question is, how well did you do it, and how do you know? That's the key piece. How do you know how well you did it? And the third is, who is better off because you did what you did, and how do you know? And that's a really simple matrix that's the equivalent of years and years and millions of dollars of evaluation. If you can answer the question, who's better off because of what you did, and how you know that to be the case, you'll be a full step ahead. I mentioned collaboration, contractual consolidation. All of those things need to be open to you right now, really looking at sustainability in the long run. and be open to new ideas. The point you made, that this can be a really fertile ground for the entrepreneurial part of you, is really an important piece. And so I don't even know if we have time for discussion, and I'm sorry if I took too much time, but I'd like to open the floor. Do we have some time for that, Henry?
We can take about 2 questions.
Oh, it's 11:20. Oh.
I'm gonna, really quick, I want to check on our phone, or to see if anyone wrote in some comments. I don't want you to be ignored.
Any
all right,
questions
no
while she's doing that? Is there anything up there?
No.
Okay. Anything? Yes, ma'am.
What suggestions do you have for collaboration between community-based organizations and MCOs, managed care organizations, to provide the support to the participants?
Well, I think you start by just talking with each other. How much do they know about what goes on in the community? Can you invite them out to visit with you and see what services you provide, and think about it in terms of their goals? How is what you're doing contributing to not just to the betterment of the person, but to the actual improved health of the person? There has to be obviously willingness on both sides to have the conversation. And if there's not a willingness, then maybe that's something your leadership council can do, is to intervene on your behalf and ask. But I've found that once people talk about these things and find ways together to count them and to account for them, that good cooperation can exist. If a health plan is not really interested in community health, you're not going to be very successful. So you may have to pick your partners carefully. I don't know where the Medicaid folks are enrolled, if they're spread across all 5 plans, if they're mostly in one plan, but I'd start with that as well. Yes? Oh. I'll let you manage it.
We have one who hasn't had a comment yet, so
one of the things that really struck me was the fact that various entities within the state have certain regulations. Has there been any attempt to bring them in to show that what you are regulating is opposed to what this one is as far as rules are concerned? I know that we put together a program here in Spokane for women, and the difficulty is the Department of Health had one batch of rules. We had the people who were doing the building had a different set of rules, and it became a very expensive proposition that because we were an agency that had been very careful with our funding, we were able to put it together, but we recognized that in our communities they would never have been able to put together a program because of the cost of trying to go with the various agencies that were doing, making rules and regulations.
Let me respond to that just quickly. They are not used to working together either. And so the state agencies, so the fact that they have all different rights never bothered anybody until now when we're trying to integrate and put things together. It was that dilemma. In New York, something called A4I, that's the project about bidirectional integration of behavioral health, substance abuse, and health. The inability to achieve that project, to achieve the goals of that project, drove the state to convene a work group to look at aligning regulations. So I chair that group at the state level for behavioral health, substance abuse, and physical health. And we've started with the things that are in the purview of the state departments that don't require legislation or don't require federal work. So we can kind of do first things first and do what we can at that level, build some experience with a combined effort, and then move on from there. So there has to be a driver to require those organizations to work together. And this work can be one of those drivers.
So unfortunately, we do have another meeting right after this one in this room, so I got to do a quick turnover. But if you have questions that you didn't get answered yet, if you want to email those questions to me, Hadley at Better Health Together, we have some time with Ann in the afternoon, so I can ask her those questions and then shoot them back out in an email blast. That goes for everyone in the room. If you have any questions at all you'd like to ask Ann, please feel free to email me and I'll pass that along. With that, I want to give a great round of applause and thank you. Thank you. And on our last final minutes, I'm going to bring up Allison just for a quick announcement about some of what.
Well, maybe. How many people have either been to the Collaborative 101 or are staying to the end? Wait a minute. No, I want to know if you don't know about the Collaborative and you're not staying. Okay, very quickly. The Collaboratives are about to launch. We're going through this 101 session. There'll be a formal, like, blah, 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 here are all the slides and everything, coming out probably the end of the week because we'll have done all of our in-persons. But the Collaboratives are really the mechanism with which the money is going to flow. So you'll want to be paying attention to that. As we've been talking about, we've got 8 different settings of work that needs to be done. Looking around, almost all of you fit very squarely in at least one of those settings. Some of you get to do lots and lots of work, so it's going to be awesome for you. We really are just encouraging folks to start thinking about engagement, the work ahead, and you will start to see a very steady stream of, I think we're going to call it guidance coming out, because the work is about to become yours to do and figure out. At next week's board meeting, we expect the first round of funds flow information to come out. So if you were inclined to listen in or be part of our public comment period from 12 to 1, this would be a good time to talk about priorities that you would have for those dollars so that we've got a good sense of community feedback. Our waiver finance group that is making the recommendation is a very multi-county, multi-sector type of organization group. So we think we've got all of our key settings represented, but would always invite your feedback. And if you haven't sat through the 101, I would really suggest you have some lunch and stick around. Is that good?
Yeah. And I'd just like to thank you for inviting me. Brian invited me, and for your attentiveness today. I know I went on too long, but we did have a discussion. And Hadley knows where to reach me if you want to have more discussion or whatever, and I wish you all the best. I hope that none of the mistakes that we made are yours to make, and only the successes come your way.
We're going to make a whole different set. We're going to learn from you and make new.
Good. Well, I want to hear what those are. Yeah. But anyway, thank you so much for inviting me, and good luck.
Thank you.